Hello and welcome to Empathy HIT. Your host, Dr. Sandy Whitehouse, is the CEO and CMO of Ticket Health, an award-winning global provider of digital solutions for capturing data directly from and in communicating with vulnerable people within diverse populations. On this podcast, Dr. Whitehouse chats with providers, partners, and industry leaders on topics ranging from digital empathy to social determinants of health, to rethinking how we collect information critical to improving health outcomes.
Margaret, you have been working with several school districts and juvenile justice organisations with an approach called SBIRT, Screening, Brief Intervention and Referral to Treatment. What motivated King County to launch this program?
Well, initially, Reclaiming Futures actually approached us in King County to potentially implement an SBIRT model within the juvenile justice system or the juvenile legal system. And when we proposed this, the juvenile court judge recommended that we move upstream, that we actually do some prevention and prevent our young people from actually getting caught up in the juvenile legal system in the first place. So then we counter-proposed to Evan Elkin, the executive director of Reclaiming Futures, to see if we could adapt his juvenile legal system model to schools. And that's how we embarked on this large project.
Oh, that's very exciting. And that transition from juvenile justice to schools is a big step. Can you speak about the SBIRT approach, why it's timely, the concept of equity, and how you have modified it to be even more impactful in identifying students in need?
The SBIRT approach is really about prevention and promotion of health. And so SBIRT is initial screening. And what we've done is we have utilized the Check Yourself screen that has been modified with the co-authors of Seattle Children's Hospital and Ticket Health. And we utilize that screen that is not just looking for substance use, which is typically what is looked for in the original SBIRT model. It's really just looking for problematic substance use. What we've done is we've really broadened that to take a look at beyond just using substances to also check in around their mental health well-being, their connections, their protective factors, and also their strengths. And it's a short screen of approximately 10 minutes, and they also receive feedback. And so based upon their answers, they will get specific feedback that would be appropriate for their age. And so when we were looking at SBIRT, this was something that we wanted to do for a long time because we're looking at more prevention interventions instead of waiting till young people are so sick that they need treatment and a diagnosis. What we'd like to do is get in front of that and start those conversations. And that's what the screen does. It's a starter for a longer conversation, a brief intervention with a trained adult. And then the concept of equity is when we were starting to actually implement SBIRT and with the screens, we started with indicated screening. So if there was a concern, maybe absenteeism, maybe there was some kind of a behavioral issue in the classroom. If there was maybe concerns around grades, then those students would get a screen and then a follow-up brief intervention. What we found was that while we were just starting the project, we really wanted to do universal screening, and just the implementation process was a little bit complicated. And so we allowed indicated screening just around the initial installation of SBIRT. And we had a process evaluation that was conducted by the Seattle Children's Research Institute. And it showed when we were doing indicated screening, based upon what we're observing as adults, we tended to overscreen Black and Brown youth and underscreen white and Asian youth. And therefore, it was very clear that we really need to move to universal screening, which now in our fourth year of implementation, we're seeing that the implementation universally is reaching the students it needs to reach now. And then how we've modified it to be more impactful, I would say that we take the feedback from the counselors and then also from the students. And so Although we just finished our third year of implementation, some of the feedback from students and the counselors is we want to change some of the questions, but we did not want to do that until we completed the fourth year of evaluation.
It's a really unique way that you've broadened that approach to SBIRT to be much more holistic around all those risk factors that can be dangerous and impact young people's development. And I understand that when you were talking about being upstream, that you started with middle schools. And so that really is even before these troublesome behaviours begin or concerns, that you're sort of creating really an early start. I'm interested to know what your results have shown and where your data comes from.
Well, our results have come from really utilizing the screen on not only to assist with the screening itself, but there's also back-end information that collects the data and then also collects the information after the brief intervention. And so we collect that information along the way. We also train our districts in how to clean that data to make sure it is accurate. And then we follow up in every year and we provide that information back to the districts so they can assist us in making meaning out of the data. And so that is really based upon the Check Yourself, the Ticket Health platform that, again, helps us actually do the screen, but also collects the data on the back end. And what we found from the data is the anxiety and depression were much more prominent than any substance use, especially in middle school. We will be moving into high school, and we know that is going to be a different audience altogether. And so we are currently adapting the screen as it stands to have an evidence-based substance use screen embedded into the Check Yourself screen.
You've done assessments in the past. Why do you think screening is so critical?
We have done a lot of different screens in the past. The most recent one is the Global Appraisal of Individual Needs, and that there's a short screener and then there's a follow-up assessment. And those are really excellent tools. What we found is it was really focused on problems and diagnoses, and there was not a balance in the screen itself. And it's not sophisticated as what we have right now with Check Yourself, where it's not just a counselor asking questions, because those screens are really based upon having a professional interview a student. This platform allows the student to take the screen at their own pace and then also get personalized feedback. And it also asks about their health and well-being, their strengths, their protective factors, and the connections to adults in their lives. And when we did a lot of research and we were looking for the right screen, and until we found Check Yourself, we didn't really see anything that was that robust as far as looking at the whole student, the whole young person.
So you may have already answered this in that question, but what do you think is the difference between the digital tools you're using today, and what role do partnerships play along with these tools?
Well, the difference with the digital tools, before we were able to collect data on the back end, and yet again, it was only collecting symptomology and problems. And so this digital tool, using Check Yourself on the Ticket platform, really allows for whoever's taking it to really kind of see themselves in the screen and not just answer questions about how their life is falling apart. Because we know our students are not just a set of problems and symptoms. They are whole human beings. And this also gives really excellent information for the counselor to follow up. And so you're not just following up on risk factors, you're also following up on strengths and protective factors.
I really like how you're talking about the whole person approach. And so what role do the partnerships play along with these tools?
So the partnerships have been critical, really working with the counselors, the interventionists. It depends on what role it could be. It could be a school counselor. Each district decides who will be doing the brief intervention. And so everyone gets trained in motivational interviewing, and it really complements the screen itself. So I would say the partnerships really have allowed us in real time to get feedback and to constantly work with our partners at Ticket Health to really take a look at what's going on the back end, like how we get the information, how efficient it is, and to continue to improve that. along the way. And so our partners are constantly giving us feedback, and then Ticket Health is working with us just to always make it more efficient. And it's just easier for the counselors to do their job instead of complicated algorithms. It's really just trying to make it a simple process to see who are the students we need to follow up with and how quickly do we need to follow up with those students.
And you feel that, you talked a little bit about efficiency. And one of the concerns has always been, don't ask, don't tell, because if you find problems, you have to do something about that. Did you find that it increased the workload for the staff and counsellors, or did it just align it better, or did it reduce the work? Where do you think that this new intervention fell in terms of that, or with respect to efficiency?
I think there was a real concern that once we start screening our students, that the workload would be overwhelming. And because the school counselors, they have a huge caseload, and it's really beyond what anybody can manage. One counselor for 300 students or 400 students, it's just undoable in a lot of ways. And so what they were doing before we were screening was just responding to those students that were externalizing some kind of evident behavior. Again, like grades, absences, maybe acting out in school. So something that was observable. And so when we actually started implementing it, it was a real concern, especially because we ask about suicide ideation. And that really raised a lot of anxiety for the counselors. And what we found is there's a lot of young people that look really good and their grades are fine. They're showing up, they're not acting out, and they're internalizing a lot of grief, depression, anxiety, and they actually endorse suicide ideation. And it surprised a lot of the counselors. And it was a very small percentage of the total population. Around 3 to 5% of the entire grade endorsed suicide ideation. And those students got a follow-up immediately before the end of the school day, or if we were in remote, right away in a breakout room. And then the other thing I heard from counselors that was super interesting is that they got to know their students that they otherwise would have never known. And even if it was just a quick check-in, maybe the symptomology wasn't so severe, but it's still a quick check-in, a quick brief intervention. And then the counselors had a connection with that student. And if that student needed something down the road, they felt comfortable enough because they've already met the counselor. So I would say the work expanded just around preparation. And once the infrastructure was put in place, it definitely streamlined all of the interventions that were going on in the school and allowed a framework that was responsive to what the capacity was of the counselors.
Well, thank you. That's really interesting. Can you talk a little bit about connection and the impact of doing this on connection with school and community, what you found there?
What we found actually through our evaluation is for the students that went through the screening and the brief intervention, they felt more connected to school and to adults in their school. So we definitely saw that that was something that increased, and it was statistically significant. And what we know is if our young people feel connected to school, they tend to do better in school and just in general.
Yeah, that's fantastic. Thank you. So congratulations on securing another round of funding to help your community continue to flourish. Why do you think your BSK program continues to be funded?
Well, Best Starts for Kids, it's actually a levy, a property tax in King County. And you would think that during this time that would not pass. And it passed with over 60% of the voters saying, yes, we need more prevention and promotion funding, because most of the county funding has always gone to the deep end, to incarceration, police, sheriffs, judges. And this pot of money is specifically for prevention and promotion from prenatal all the way to 24. So we are one of a dozen or more strategies to really provide a continuum of really building this happy, healthy, thriving young person until they are in their mid-20s.
Oh, I'm already inspired. But for the last question, I wanted to ask, what were some of the other things that you've seen along your professional journey that were just so inspiring to you? And what were some of those pit stops that really kept you fired up?
Well, I have spent most of my career working in the juvenile legal system, and I have seen young people that have spent so much time incarcerated, and they've spent so much time in treatment centers and less time in school. And then also, when we look at our data across our state, it's our young people that are spending time in our behavioral health system. The likelihood of them graduating is dismal. And so we've spent so much time removing our young people in institutions that we're pulling them out of the very thing that they need to help them be successful, and that's school. And so for me, what has been so inspiring is really this particular strategy is really to keep our young people in school and also connect with them. And what I'm seeing too is the counselors themselves looking at the data, and they are saying, okay, based on our data, because we have so much anxiety in our school, we need to implement something on a universal level around social emotional learning. And because we have the data specific for our school, we can look for a curriculum that makes sense for us. It's something that's specifically for their own school. Beyond the district, you can have 7 schools in one district, and the 7 schools look very different from each other as far as their needs. So for me, this has been the most inspiring project I've been able to work on, and I just feel really grateful for it. And I would say some of the pit stops that keeps me fired up is really just a lot of the bureaucracy. And yet I'm determined to continue to work through it and make sure that there's somebody that's looking out for our children when they're out of our house.
So thank you, Margaret. It's so exciting to hear it directly from you and to see the impact and effect. So thank you very much for joining us today.
Thank you for joining us today. You can follow the conversation on Empathy HIT on Healthcare Now Radio or at tickethealth.com or at #DigitalEmpathy. And be sure to follow Dr. Whitehouse on Twitter at Sandy Whitehouse.